Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Scott Tzorfas. He's a neurologist. Today's Kevin MD article is The Crushing Bureaucracy That's Driving Independent Physicians to Extinction. Scott, welcome to the show.
Thank you for inviting me. I appreciate this opportunity.
All right, let's start by briefly sharing your story, and then we'll talk about your Kevin MD article.
All right. First, I'd like to give a little background on me so you can understand why I'm an independent physician, why I think it's important to preserve physician autonomy. I grew up on the Jersey Shore, was always very independent. In high school, I had a poor science background. I literally had to teach myself science, chemistry, physics, and summer classes in community colleges and universities. My father owned an independent pharmacy, which is quite uncommon today. When I was a young boy in the early to mid 70s, I always worked in his store. And back then, there was a program called the PAD, Pharmaceutical Assistance for the Aged. So you had to fill out an onion skin, his carbon copy, you sent it to the state to get paid, and I filled it out correctly. I think I forgot to put his $2 fee so that he would get paid for that prescription. So he said to me, listen, I don't work for nothing. And that has stayed with me my whole life. I've negotiated with insurance companies for 25 years with that philosophy. I started my own practice with very little help. I've been an independent solo practice doctor for 30 years, and this independence has been very important to me and has really helped me. Started my practice from scratch at a time when referrals were key. I worked at 3 local hospitals, and I built up my referral base, but I always worked in the office. Now it's 180 degrees difference. Most of my referrals come from the internet and Google. I'm involved in every aspect of my practice, not just being a good neurologist. 50% of my time is running this business. Several years I've been active in trying to preserve physician autonomy and improve patient care. I have a Substack article, as well as articles and videos on the internet. I even drafted an executive order to help immediately increase the number of private practice doctors. I've been on radio and TV shows. My Kevin MD article discusses the crushing bureaucracy that is affecting private practice physicians. But before I discuss the article, I think it's important to give some background on this problem that has led to such a dramatic drop in private practice physicians. Because of this reduction in private practice physicians, there are wait times of more than 6 months to see a specialist. Near me, Philadelphia, big university hospitals, there's literally a wait time of almost a year for some neurology subspecialties. 15 years ago, 75% of doctors were in private practice. Now only 25% are in private practice. That's a huge shift in 15 years. The AMA will give you a figure of 43%, but that includes very large private practice groups and some private equity-backed private practice, which I don't think is true private practice. Doctors now work for large healthcare systems, hospitals, and corporate entities, and this is called vertical integration. This was started during the first part of the Obama administration. I believe it was intentionally to drive doctors out of private practice and into hospitals. This was done through increased government regulation and decreased reimbursement to private practice doctors. The largest motivation is profit, and this undermines competition and drives prices higher. Why is this? I can give 4 reasons. Number 1, hospital physicians earn more than their private practice counterparts. I think this is the biggest reason. It depends on the CPT code for service offered, but for office visits, hospitals earn 2 to 3 times more for the same visit than a private practice office. Hospitals earn a facility fee on top of the professional fee. For echo and MRI, it's 3 to 5 times more. People follow the money, and doctors, unfortunately, are no exception. Where I am in New Jersey, there's literally 5 to 10% of cardiologists are in private practice. Number 2 would be MIPS and MACRA, acronyms for government regulatory requirements, which was started in the beginning of the Obama administration. And clinicians didn't sign up to be data entry clerks. We want to heal, to innovate, and to connect with our patients, not to chase arbitrary scores that don't impact the people we care for. This regulatory burden was the start of private practice physicians leaving to join hospital and large corporate entities or retiring. To many people, it doesn't enhance patient outcomes. When a patient sees me, I give them full time and attention, and I can do this because I control my practice. The other thing I just want to briefly talk about is something called the Misvalued Code Initiative, also started around 2013. Fees were slashed over 50% for many procedures. Reimbursements for echocardiograms were severely reduced for cardiologists in private practice. That's the main reason why cardiologists left private practice at that time. I do a procedure called an EMG, which looks at nerve and muscle. My fees were reduced over 50% for that procedure. This misvalue code initiative affected small to medium private practices. Hospital employed physicians were often shielded somewhat because their overall compensation could be adjusted internally, and hospitals could absorb some of that revenue reduction. Private practices, understandably, had less flexibility. Number three, complete lack of physician autonomy. There are immense regulatory and administrative burdens, such as EHR mandates and pre-certification and authorization requirements. I can talk about more of that in a second. Number four, which is very distressing to me, young doctors are not offered the ability to explore private practice options. They are not encouraged, and the system is not there to support them. We need to change that. So that's the foundation.
So let me ask, you said that 50% of your time is spent on
Yeah.
administrative tasks. So tell me about your typical day. How do you balance both what you do clinically with the administration you're talking about in managing an independent practice?
Well, I have a day set aside just that I can do the things that I have to do. My office, I'm really a dinosaur, Kevin. I'm so small, it's just me and my wife in the office. So I see the patients, but I have to decide, what types of patients I see. You have to balance these things. Patients might have a large deductible, a large coinsurance. So those kind of things that if you work for a hospital, you don't even think of those kind of things.
Mm-hmm.
You have to pay the bills. So those administrative tasks, which I could talk just a second, in the past 3 months, I had to change my billing software. The billing software I had for over 20 years was bought by private equity, and I just
Mm-hmm.
didn't want to go that route. My QuickBooks got completely changed. I had to do that. And my phone service, I had to change to internet phones. So that's just an example of the last 2 to 3 months of something I had to deal with. But I really feel the positives always outweigh the negatives.
All right. And certainly I want to explore more about why you do what you do in independent practice, because like you said, only a minority of physicians are entering independent practice these days. Your Kevin MD article talks about this crushing bureaucracy that's driving independent practices to extinction. For those of you who get a chance to read your article, just briefly summarize and share what it's about.
All right, so I talk about how pre-certifications and authorizations crush private practice doctors. The AMA did a survey that showed the typical office does 40 prior authorizations per week. My office spends hour after hour getting simple tests and medicines approved. Even simple headache medicines need prior authorizations. Generic medications, which even 5 years ago, you didn't have to get generic medications with prior authorizations. All MRIs need prior authorization. I can't function. I can't function as a neurologist without an MRI. And for some of the private insurance or commercial insurance near me, I cannot get an MRI of the cervical spine. I can't tell you why they don't want to do an MRI of the cervical spine. They'll do a lumbar spine, but they won't do a cervical spine.
Mm-hmm.
When you think about it, a cervical spine can cause a lot more problems if you have a myelopathy or compression of the nerves in the spinal cord. It doesn't even make any sense. So large hospitals can handle this kind of paperwork. Small practices can't. And this regulatory burden really is huge. I have to constantly click off boxes to conform to quality metrics for MIPS. We also get billing audits every day through the fax. So in my article, I have a link that your audience can click on to sign a petition that talks about all of this. It has over 300 signatures and has been viewed 24,000 times. I want to bring this petition to policymakers. I've applied to the Federal Healthcare Advisory Committee, which is a 15-member panel that Medicare has started. They're going to make their decision in a month, and we'll see what happens. But I want to have a seat at the table. I want to represent small private practice physicians. So we should be doing the right things for patients, not for big pharmaceutical companies, not for corporations. Concentration of corporate power is really killing America. I just want to mention one part of the Affordable Care Act. There's a perverse incentive due to the ACA. The ACA limits insurance profits to 15 to 20% of premiums, but that's a percentage, not a dollar cap. So if premiums go up, insurers make more money. In other words, higher premiums can actually increase profits while staying legal, which partly explains why ACA costs keep climbing. I always couldn't understand, why do insurance companies want to pay hospitals more money? And it's because if they pay them more money, then they can charge more premiums, and then the insurance company can make.
So one of the things about pre-authorization is that a lot of the decisions and denials come from physicians not even in your field, and sometimes they're not even from physicians at all, right?
God, I think a lot of them are from AI at this point. It's really automatic. It almost doesn't matter. They want my notes. I don't think it matters a lot of times what's in the note. It is in some extent it's automatic. And if you're in small private practice, you can't stay on the phone. You can't talk to people. You used to be able to talk to a doctor as part of the insurance company and you would get an authorization number. It was really that simple. Now, I won't mention the insurance company, but they'll only do a consult. So even if I got on the phone, the person tells me, well, this is only a consult. I can't approve it. This is the red tape that you go around in circles with insurance companies.
Now, with all these obstacles that you mentioned, whether it's pre-authorization and sometimes the difficulty finding patients and referrals and the administrative work, why do you still do independent practice after all these decades? What prevents you from, say, selling to private equity or joining a hospital group? What keeps you going in independent practice?
Well, 15 years ago, when all this started with the Obama administration, I really dug my heels in with that. The AMA and the American Academy of Neurology really didn't support private practice doctors. So I remember the American Academy of Neurology, when all this was going on 15 or so years ago, they really said, maybe you should join a hospital so you can get your referral base. I mean, can you imagine that? That was the support that I got. So I took a gamble, but as I said, with the internet and Google, I am busier now than I was 15 years ago. I I think it's important to have control over your own practice. Like I said, I don't click off boxes. I look at my patients, they have my full attention time. When I talk to patients who go to a lot of these large hospital clinics, that's not always the case.
Hmm.
And I don't want to say that big hospitals give bad care. I'm really not saying that. But patients should have the choice. Doctors should have the choice what kind of care they receive. And a lot of patients really want to come to my office. They want to know they only see Dr. Tzorfas or not somebody else in that seat. For me personally, and I think for young people, it's true, Kevin, that if you just encouraged young people, they would want to be entrepreneurs. I think that's part of the American or human spirit is to be an entrepreneur. You just have to encourage them and give them the support.
One of the things you mentioned earlier is that a lot of physicians in residency, they don't get a lot of exposure to independent and private practice. And sometimes that skews their decision to stay in large hospital systems because they're just not aware that there's another world out there, right? So how do you recommend remedying this? How can we get more medical students and residents aware of the private practice model and maybe have some rotations is to get them more exposure to that model because they're not often exposed to that during their training.
I've given this a lot of thought, and I think one of the problems, my son is in medical school. He has a friend that wants to go into private practice, and I've counseled him about that because they don't get any of that exposure. I don't know if a nonprofit would help something like that. I don't know if enough people would support a nonprofit. I think it would start with the medical schools, and I think this administration would have to understand the problem and want to, well, first, the doctors left because hospitals were paid more money, because the administrative tasks were made too burdenful. So I think just partly, if you reversed all that and at least paid private practice doctors equally, I think that would help. If you gave them a tax incentive like the qualified business income tax deduction and applied that to doctors. So all these incentives, if you reverse them, but you've got to get the medical schools to want to do that. And they're so focused on their mindset and what they do. That is the most challenging problem, I think. But intrinsically, I think you get about 20% of medical students, I think easily would do it. When I finished my residency, I think it was like 2/3 were going into private practice.
Hmm.
All the incentives changed. I think if you change the incentives back to where they were, people will follow. People, will follow that path. And as I said, people follow the money.
So speaking of money, let's talk about private equity. So across fields, whether it's emergency departments, gastroenterology practices, practices across specialties, private equities buying up these independent practices. And for these physicians, rather than fight this administrative battle that we talked about here, they're just selling the private equity and taking the money, right? So talk to us about what do you think about that trend and the implications for that for both doctors and patients going forward?
Well, probably older doctors who were going to retire. I would imagine that that was a decent amount of people selling their practices to private equity. I think it's a matter, again, of reversing those incentives. Now, let's talk about one aspect, repealing restrictions on physician-owned hospitals. Doctors should be able to own their own hospitals and MRI machines. You want to reduce the burden financially and administratively for doctors to own their own surgery centers. Near me, there were a couple of surgery centers, but because of this administrative burden and the financial incentive, they sold it. It would be a long process, but physician ownership, and this has been shown in physician owned hospitals, they incentivize efficiency, quantity, and lower overhead, all which helps to reduce the overall cost of care, especially for elective and specialized procedures. So the answer I can give you to this is incentive, site neutral reimbursement, level the playing field. This will also save Medicare billions of dollars. That's been shown. There's been studies that show that. Medicare payment to physicians is not keeping up with inflation. If you look back to the year 2000, doctors are earning a third less when you incorporate inflation. So, I wish people didn't give up so easily. Like I said, I didn't give up easily, but I think there's a way out of this if you incentivize people to join private practice. And the reality is the wait times are huge. I mean, when I say 6, 9 months a year, my local hospitals are almost 6 months booked. So people are looking around the internet. You got to get more doctors into the system. And that's how you do it.
We're talking to Scott Tzorfas. He's a neurologist. Today's Kevin MD article is The Crushing Bureaucracy That's Driving Independent Physicians to Extinction. Scott, let's enter some take-home messages that you want to leave with the Kevin MD audience.
I think the biggest is to be convinced of your convictions. There isn't any amount of money you could give me to join a large healthcare entity or hospital. Like I said, I have an intrinsic entrepreneurial spirit. Many patients want to see small private practice doctors. And if you don't like working for a hospital or large healthcare system, there's a way out of this. You had a podcast of a woman who actually helps private practice doctors. So that's a way people can help you. You can really do it on your own if you start slowly. And, I think the other take home message is we want to get young people encouraged to join private practice. Lastly, one thing I want to say, failure is okay. We're always taught about success. I think failure is what shapes who you are and what you need and how to change.
Scott, thank you so much for sharing your story time and insight. Thanks again for coming on the show.
All right, my pleasure.